First, I want to extend my welcome to my colleagues and all our guests. Just a minute, okay. And thank you so much for being here. At first, I want to thank my young colleagues to accept to present in this session, especially Dr. Movahedi and Dr. Asna Ashari. Dr. Kosar Asna Ashari, our first speaker, is an assistant professor of pediatrics working in our center, and we hope she will become our fellow very soon. So first presentation is by Dr. Kosar Asna Ashari, and the second presentation by Dr. Movahedi. Dr. Nasim Movahedi is our pediatric rheumatology fellow, and she will graduate on September, so we can say that now she is potentially a pediatric rheumatologist. So first, Dr. Kosar Asna Ashari, you can start your presentation, and we are waiting to hear your presentation. Thank you so much.
Thank you very much, Professor Sadevi. Hi, ladies and gentlemen, and my greetings to Dr. Thomas. I'm Dr. Kosar Asna Ashari, Assistant Professor of Pediatrics at Children's Medical Center, Tehran University of Medical Sciences. I'm proud to be here today presenting to you one of our cases with the diagnosis of C1q deficiency. Our patient was a 23-month-old girl born to consanguineous parents. She presented with postular facial skin lesions and developmental delay. And this developmental delay was found since at the age of 12 months. She was unable to stand and walk when she was admitted at our hospital. She also had poor weight gain. Her birth weight was 3 kilograms and her admission weight was 8 kilograms. And there was no previous significant infection or hospital admission. Here you can see the postular lesions on the face of this infant as she was presented to our hospital. So up to this point, we had some differential diagnosis in mind. Considering the manifestations of the child, we had metabolic and nutritional diseases in mind, like pellagra disease, because of B3 deficiency, also zinc deficiency and porphyria. There were some primary immunodeficiency diseases that we had to consider, like Shediac-Higashi syndrome, also hyper-IgE syndrome, and complement deficiencies, and also inflammatory diseases like SLE, about which we are going to discuss when we see the laboratory evaluations. Okay, so here we can see the laboratory evaluations of our child. The WBC count was 7,800 cells per microliter, and the lymphocyte count was 4,300. Neutrophil count was 2,400, which was relatively low for her age. The monocyte count was 1,004. Hemoglobin level was also decreased. It was 7.3, and the RBC count was 3.19 millions. The MCV was also decreased, it was 66, and the platelet count was 259,000. The Combs test was negative, the retic count was 2.1, CRP level was 8, and ESR level was increased, it was 94. As you can see, there was an elevated value of IgG that was 1,901, IgM level of 271, IgA level of 364, and elevated IgE of more than 500 was reported. As C3, C4, and CH50 levels were investigated, we found that CH50 was decreased. It was in fact undetectable. ANA was 5+ positive, FANA was positive to the value of 1 on 360. Antiphospholipid IgM and IgG were negative, and lupus anticoagulant level was normal. CD markers were also investigated, as CD3, CD4, CD8, and CD19 and CD16, 56 can be observed here, the values within normal ranges. And the anti-tetanus and anti-diphtheria levels were also normal, which can show that probably there was not a primary immunodeficiency of humoral origin. And the MBT test was also normal, which can rule out the granulocyte dysfunction in the primary immunodeficiencies. And the AFP level was also normal. So further, excuse me, further investigations were done for the child. The brain MRI was normal at that point. And there was this skin consultation, well, they suggested that we consider the primary immunodeficiencies and metabolic disorders regarding the pustular lesions that the patient had on her face. We also had cardiac counseling and echocardiography, which revealed normal results. Genetic study was requested, and the patient was discharged with prophylactic cotrimoxazole. The patient then was admitted again within 2 months with a complaint of fever, exacerbation of skin lesions, mouth ulcers, non-fitting edema of lower extremities and arthritis, and severe neurologic symptoms. Chest X-ray was normal. I do apologize for my voice. And abdomen and pelvic sonography were normal. Brain MRI here showed diffuse cerebral cortical atrophy. As I mentioned, the neurologic symptoms were deteriorated at this point. And the three-phasic bone scintigraphy showed mild to moderate multi-articular inflammation in the wrist, ankle, and knee. So again, you can see here the laboratory evaluations. Here we have decreased level of white BC, 2,400, decreased level of lymphocyte, 1,350, decreased level of neutrophil, which is 850. The monocyte count of 230, hemoglobin level still low, RBC level low, MCV level low, platelet count was normal, and CRP here was 18, ESR was 34, Combs direct and indirect were both negative, and reti count was 0.3. Here we checked a C1 inhibitor. As you can see, the result was 40, was within the normal ranges. ANA was still positive. Anti-double-stranded DNA was negative. RF was 3+ positive. Urine analysis revealed normal results. Urine calcium to creatinine level was slightly increased. Urine protein to creatinine level also slightly increased, 1.6. And anti-RNP SM antibody was 3+ positive, anti-SM antibody 3+ positive, anti-SSAA 3+ positive, anti-RO52 antibody was positive 3+, and anti-ribosomal protein was 2+ positive. FANA was positive to the value of 1 on 1,280. T3 and C4 level also normal, and CH50 was still undetected. So as you can see here, the SLICC 2012 criteria, considering the manifestations of the patients, we can say that the lesions that the patient had could be categorized in the chronic cutaneous lupus category. Also, the patient had oral ulcers. She had synovitis in more than 2 joints. She had renal manifestation of the increased porphyrin to creatinine level. She had the neurologic manifestations. She had leukopenia, and in the immunological criteria, she had positive ANA, positive anti-SM, and low CH50. As we all know, for fulfilling the criteria for SLICC, at least the clinical criteria, one at least in immunological criteria, and the patient fulfilled the SLE criteria. Okay, so here the genetic study was ready. Whole exome sequencing, also confirmed by Sanger sequencing, found a mutation in C1q8 gene showing C1q deficiency. You can see, and the parents of the patients were both heterozygotes for this mutation. You can see the pedigree here. The parent was heterozygote and the patient was affected. So what we did for this patient was to transfuse FFB as is recommended in C1q deficiency in monogenic SLE, in fact, and steroid pulse followed by oral prednisolone was prescribed, also hydroxychloroquine, prophylactic cotrimoxazole, and skincare. Our patient was referred for hematopoietic stem cell therapy. The donor was the mother. After the HSCT, the patient had a very favorable response to HSCT. The skin lesions healed, and the patient was having a favorable course of disease. She did not experience any severe infection. She did not experience any course of GVHD. Nevertheless, after 1.5 years, she unfortunately died due to sudden death. The reason for this death was not clear. It was suggested that it was due to cardiomyopathy, as we have sometimes in patients that are going through the remission therapy after GVHD, but the patient did not have any infection on the day that she passed away or any presentation of GVHD. Thank you very much for your attention.
Thank you so much, Dr. Kosar. I know you are a little bit sick, but because of the COVID infection, but you showed your commitment to the pediatric rheumatology field.
I will always do that.
And thank you so much.
My honor. Thank you.
Is there any question about the patient? I see no question in the chat box. So we can continue for the next presentation. Okay.
Yeah, just a short question. Was there performed an autopsy when she died?
No.
No autopsy was done. No.
Okay. Dr. Kosa.
No. I talked to the parents. She recently died. Unfortunately, it was 50 days ago. They did not want to do any autopsy.
You know, Niels, that was a sudden death in the home. Yeah. At the home, we can say, and that was a terrible accident for the parents, and also for us, because we didn't expect this result for this patient, because all the manifestations and all the complications were gone. But suddenly that happened, and we don't know why. Okay. Dr. Salehzadeh, sorry, I cannot speak very well, because when I speak, I can hear you through my headphones again, and there is a double echo in my mind. So sometimes I forget what I want to say. Okay. Dr. Salehzadeh asked a question. Did you find any reason for a high level of IgE?
As far as I know, no reason was found. Hyper-IgE was in the DDX, but as you know, the net diagnosis for hyper-IgE is the genetic analysis. So when the genetic analysis could not find any mutation in what we expect, like in DUC8 or TYK2 or in STAT3 genes, instead we found this mutation in C1q.
Okay, thank you so much. Okay, let's go to the next presentation. Dr. Mobahedi, we can say the podium is yours.
Hello, thank you, Dr. Sadeghi. Let me thank our dear participants for joining us today. I will describe another case of monogenic SLE. Our patient was a 3.5-year-old boy who first presented to our rheumatology clinic at Children's Medical Center because of prolonged fever and skin lesions. All the previous workups to find any infectious cause for this prolonged fever failed, and so he was referred to our clinic. He was a second child of a consanguineous marriage. He was born term at 2009 with birth weight of 2,800 grams. The first child of this family was died at age 3, and he had meningitis, hydrocephaly, and refractory seizure. For our patient's past medical history, his neonatal period was unremarkable, and he didn't have any serious infection or any hospitalization. When he was 1 month, he had a focal seizure. He had chronic movements of left lower limb, and the diagnosis of seizure, he was started on phenobarbital. When he was 6, he had some skin lesions, erythematous plaque over his cheeks, and it was time that it was a sort of malar rash and discoid rashes. He also had a developmental delay in terms of gross motor and language skills. He could not walk alone at age 2, and also just said 2-word sentences when he was 3. At age 3, he had complex cerebral convulsion, and again an anti-epileptic drug, namely carbamazepine, was prescribed for him. A few months later, he presented with a prolonged fever for more than 3 weeks. He also had limping and skin lesions. Upon a physical examination, he had discoid rash, severe oral ulcers, alopecia, Raynaud phenomenon, and also arthritis of small joints of hands, feet, and knees. Also, he had a spastic gait and upward plantar reflexes and a 3+ DTR, all indicative of involvement of upper motor neuron. So we performed some laboratory results, and you can see here the results. At the presentation, he didn't have any leukopenia nor lymphopenia, but he had anemia, no thrombocytopenia, but ESR was elevated, ANA, and double-stranded DNA was positive. Complement level, including C3, C4, and CH50, was within normal range. Antiphospholipid antibodies and anti-lupus anticoagulant was negative. Urine analysis was normal, and also renal and liver function test was normal. Based on his signs and symptoms, and by ruling out other causes of this prolonged fever, we concluded that this patient was a case of SLE. And also he fulfills the classification criteria for SLE based on ACR 1997, and also he fulfills the criteria, the new criteria by EULAR ACR 2019, and he gets above 20 points with this classification criteria. I have mentioned some of his signs and symptoms, including fever, seizure, all the skin lesions of SLE, and musculoskeletal involvement that this patient had. He also had a positive double-stranded DNA. Cardiac evaluation revealed right bundle branch block, and because he had signs of upper motor neuron involvement, we performed brain MRI and MRV for this patient, which was normal. So with diagnosis of SLE, we prescribed prednisolone, hydroxychloroquine, nifedipine, and azathioprine for this patient, and he was discharged. His symptoms and especially skin involvement get somehow better, but not completely resolved. And he had 3 more courses of hospitalization for severe mucocutaneous lesions, and each time he was admitted to our hospital, he received corticosteroids, and once he had super infection of these lesions, so he was treated with antibiotics also. At age 7, he had proteinuria of 1,380 milligram per day. So a renal biopsy was performed for him and revealed class 5 lupus nephritis. At that time, azathioprine was changed to mycophenolate mofetil. And since this patient was product of a consanguineous marriage and a boy in early onset lupus, we requested whole exome sequencing for this patient and also requested to check C1q level. A few months later, he came with scrotal swelling, and our initial diagnosis for this patient was epidemorchitis. At that time, creatinine level was 1.1. He was discharged, but unfortunately, he received gentamicin outpatient without our prescription, and then hospitalized 10 days later with abdominal pain, respiratory distress, peripheral edema, and cola-colored urine. Upon physical examination, he had hypertension, rolls over lungs, and he was obviously volume overload. Lab results revealed creatinine level of 3.8 milligram per deciliter, and also he had proteinuria, hematuria, and electrolyte imbalances, and a case of nephritic syndrome. So medical intervention to correct this acute and chronic renal failure started, but unfortunately he had poor response to medical therapy, so hemodialysis was started for him. Eventually, he developed DIC and severe bleeding from dialysis catheter. He was intubated, and unfortunately, after a month of hospitalization, he was expired at age 8. After that, we received the result of whole exome sequencing for this patient, which revealed homozygous variant in C1QC gene. And at coding a part of this gene, nucleotide C was transformed to G on position 672. This mutation is a stop-gain mutation, an important part of this gene, and it may cause C1QC deficiency. I say may because this mutation and this variant is not reported in the literature till now, but this mutation is important and in the coding part of the gene and will cause a stop-gain mutation. So our case was a case of C1QC deficiency. Dr. Sadeghi, if there's any question, I'm willing to answer. Otherwise, I will progress to explain some slides about monogenic lupus.
Okay, I see no question on the chat box. Is there any question about the case? Okay, Dr. Nassim, you can continue.
Yes, thank you. So we presented 2 cases of monogenic SLE, one with C1q A deficiency and another with C1q-C deficiency. To talk about monogenic lupus, it is good to know that up to 100 susceptibility loci for polygenic multifactorial SLE and more than 30 genes causing the monogenic 4-1 SLE and SLE-like phenotypes have been described. The term monogenic lupus has been introduced to denote SLE patients who carry high penetrance, either dominantly or recessively inherited pathogenic variants in a single gene. Among these rare monogenic forms of the disease, mutations in the gene coding for complement pathway are the first described. So then to think about the monogenic lupus. Monogenic lupus should be taught when we have SLE present in very early age in life, usually before 5. When there is severe manifestation, especially in severe involvement of cutaneous and CNS. When the child is product or consanguineous marriage, or when there is a familial history for SLE or other autoimmune disease in the first degree relative of the patient. I said that more than 30 genes are involved in pathogenesis of monogenic SLE. Some others have classified these genes based on the pathways that are disturbed with mutation in these genes. For example, some genes cause mutation in some genes will cause a complement deficiency. C1q, C1r, C1s deficiency may cause monogenic SLE, also C2 and C4 deficiencies. About C3 deficiency, there are rare reports of this mutation that will cause monogenic SLE, but it's somehow doubtful that it will cause SLE. Another pathway that may be disturbed and will result in monogenic SLE is an interferon pathway, type 1 interferon pathway, and upregulation in interferon producing genes may cause lupus, such as defects in nuclease activity for RNAs and DNAs will cause monogenic lupus. Other genes such as PRKCD gene will disturb cell tolerance and will cause lupus by this way. And there are other genes that are not characterized till now, such as LAG1, LAG2, FAS and FAS-ligand genes, which mutation in these genes will also cause monogenic lupus. So to talk specifically about complement deficiency, the strength of association between complement deficiency and lupus depends on the position of the missing protein in the cascade. The frequency of lupus or lupus-like phenotype is approximately 90% in patients with C1q deficiency, 65% in C1r or C1s deficiency, 75% in C4 deficiency, and about 10% in C2 deficiency. Compared to polygenic form of SLE, more severe disease course, frequent cutaneous manifestations, and a high mortality rate are reported. The phenotype of patients with early complement deficiency can be more severe due to recurrent infection. About C1q deficiency, C1q has an essential role in two mechanisms associated with autoimmunity when these are deranged, such as the clearance of apoptotic cells and the maintenance of immune complexes in solution for the waste disposal hypothesis. Also, C1q is a negative regulator of type 1 interferon production. C1q has been shown to prevent an aberrant effector CD8 plus T cells response to viral infection. In this slide, you see the schematic view of the C1q subunit. C1q consists of three chains, A, B, and C chain, and this bucket-like subunit has 80 chain. From each chain, this subunit has 6 copies. So mutation in each chain will cause C1q deficiency. Our first patient had mutation in C1qa chain, and our second patient had a mutation in C1q chain. About treatment of early complement deficiency, treatment includes a standard immunosuppressive therapy used for idiopathic SLE. Especially in patients with C1q deficiency, replacement therapy with erythropoietin plasma has been reported. As in other interferonopathies characterized by interferon signature, the use of JAK inhibitors may be potentially beneficial. For severe deficiency who are refractory to treatment and have severe manifestations, bone marrow transplantation has been curative. Also, for early complement deficiencies, the major risk with infectious seems to be associated with streptococcus pneumonia and H. influenza. Thus, prevention of infection is desirable, and vaccination and prophylactic antibiotic should be given consideration. Also, management of cardiac risk factors is of heightened importance in early complement deficiency, and because these patients has accelerated atherosclerosis. To take some message, so we should consider monogenic cause of SLE when we have early onset disease, the child is product of consanguineous marriage, there is familial aggregation of autoimmune disease, and also when we have severe organ involvement, especially skin and CNS involvement, such as our two patients both have had severe skin manifestations and also CNS involvement. We should consider monogenic lupus in these cases because some of these mutations and some of these lupus patients may need different treatment other than usual lupus treatments. Thanks for your attention.
Thank you so much, Dr. Nassim, for your presentation. Okay.
Thank you, Dr. Sadeghi.
Okay, is there any question? I see no question in the chat box. So that was a presentation for some kind of monogenic lupus and some condition that could facilitate the manifestation of lupus erythematosus, especially in the young children. So the messages that Dr. Nassim presented was very important for us, especially for us who works in the field of pediatrics, because all lupus patients are some kind of different from the adult patients. Sorry, I can't. That was very critical for us for diagnosis of this patient and also for managing this patient. So because as you can see, there are some kind of different treatments for these patients. I mean, in adult patients, normally we don't use FFP for treating lupus disease, but in this kind of patients, especially those who are deficient in different component of complement system, we have to use some kind of substitute for these deficiencies. And most of the time, FFP is very suitable for treating these patients. Also, I think in the next side of the spectrum, JAK inhibitors are very important to treat and to control the disease of these patients. Dr. Salehzadeh, I say hello to you, and let me see what is your question. Therapy in these patients should be long life. Is that right? You know, this is some kind of a genetic disorder that most of the time they are deficient for their lifetime. So it depends on the manifestation of the disease and the severity of the disease, because we have to keep in mind that deficiency of these components are not just like 0 and 1. There are many variable deficiency between these two spectrum. So in some conditions, they might have manifestation of the disease in this time, or flare up the disease in this time, we have to empower our treatment, and sometimes the level of the I can say the level of the component is enough for holding the patient right. So I think this is my idea. It depends on the severity of the manifestation and the general condition of the patient. But it's very important to when we want to transfer this patient to the adult service, keep them notice that this kind of lupus is some kind of different from the ordinary lupus that they see every day, and they have to consider this kind of deficiency in their patient. Is there any comments from my colleagues or Dr. Niels? Do you have any comment about this? I will be happy to hear from you all.
Thank you for two very interesting cases. I work in a quite small hospital, and these conditions are rare, and I have not seen them. So it's very useful to see how this is presented, and I guess we would have seen them if they have been as severe as these two cases. But as you said, there are a spectrum where we also will have, I guess, more not so severe cases, and to think about this diagnosis is very important. So I would just say thank you for two excellent presentations, and I will make a summary to my colleagues, and so they know what we have been talking about.
Thank you so much for your notice. We recorded this program, and I will send you the link for you and for your colleagues to see this presentation if they what we can say, if they want, or if they are looking forward to what we are talking about in this program. Or if they like to know more about this kind of diseases. You know, the consanguineous marriage in our country is very popular. Not very popular, I can say it's popular. We see these patients more common than the other countries, that the consanguineous marriage is not very popular. Not say popular, I can say it's common. It's more common than the other countries. So maybe these diseases is more common in our country. Is there any question or comments from my...
Dr. Sadeghi, may I ask a question?
Okay, you are the presentation, so you cannot ask question. You must answer the question.
Yes, I have a question in mind that I always discuss with my professor and you, and this is that when we refer these patients, I mean patients that have complement deficiency, when to refer these patients for hematopoietic stem cell transplant. I mean some opinion exists that we refer these patients when they have severe symptoms and they are not controlled with usual lupus medications. But some other experts, I mean especially immunologists, prefer to send them for transplants when at earlier stages, and they do not consider that if they are controlled or not. And they say that this is complement deficiency and should be then transplant should be done for these patients. I'm always wondering that is it beneficial for the patient who had complement deficiency, but he's well controlled with at the minimum level of prednisolone or hydroxychloroquine, to refer this patient for transplant, or to wait to see the severe manifestation of the disease and then refer this patient for transplant. This is my struggle, and I always think about this. Is it beneficial for the patient to send him early for transplant or not?
You know, your question is some kind of ethical question or philosophical question, because there is always a struggle in minds of the physicians when it is the right time, or we can say when it's the right time to refer this patient for hematopoietic stem cell transplantation. Is there any comment about Dr. Nassim question? I personally, you know, in this situation, I think it's better to consult with the family. Maybe if the disease is controlled by the medicine, by your treatment, which is what we can say, which the quality of the patient's life is not affected by your treatment. Maybe it's better to continue your treatment. But when the quality of life is not good enough, maybe it's better to choose another treatment, or what we can say, to choose another option to treat this patient. Also, before answering this question, let me read Dr. Salehzade's comment. He wrote, I think we need new criteria for this type of SLE. Classic criteria is not sufficient and sometimes misleading. Early transplant and which patients should receive the transplant depends on patient's condition. Maybe he agrees with me in my idea. He wrote in my idea, and also I said that right. Okay.
Thank you, Dr. Sadeh.
And Dr. Kausar send a post about the Dr. Salehzadeh about new classification criteria. Okay, Dr. Ziai sent a post. Dr. Ziai is chief of our ward and professor of pediatric rheumatology. Dr. Ziai wrote, if patients have end organ involvement such as kidney, CNS, they should be candidate for hematopoietic stem cell transplantation. Okay, that was a good comment. Okay, Dr. Asari, do you have any comment?
I want to say thank
Speak
you.
a little bit louder.
Yes, that's okay.
Yes.
Thank you, and we are honored to have Professor Nims here and the other colleagues here about the monogenic, the interesting title, Monogenic Lupus. Yes, as Professor Salehzadeh and Professor Ziai said, we have we are struggling with the new lupus in pediatrician studies that they have the CNS and skin involvement especially, and the other organs such as liver or kidney is less involved. And about the monogenic lupus, about the especially the complement deficiency, the C1, I think when we have a C1q deficiency in lupus, because in addition that C1q is the initiator or component of the complement pathway for clearance of the immunocomplex and clearance of the antigen. The other function of this C1q is the tolerance and clearance of autoantigen in our body, and also inhibition the interferon 1 in our patients. So when we have the C1q deficiency mutation, we have the elevation level of interferon 1, and such as the first version, we have the presentation of hyperinterferonopathy, the high level in the interferonopathy pathway involved in addition to complement deficiency. We have two pathways involvement, and in this situation, the JAK inhibitor could be helpful for us in treatment. But when we have C2 or C4, the other component of complement pathway, maybe the anti-interferon treatment could not help us in the treatment of these patients. And such as we know the syndrome C1q, it could be in addition to interferonopathy, we have the C1q deficiency. Both pathway or pathway and involved in this two condition. Yes, and hopefully about the Dr. Movahedi comments. Yes, we really maybe we don't know what's happening in future, and when we should decide to transplant this patient. It really depends on the patient's condition, but when we should decide this HSCT, because maybe our patient have a bad condition, we wait, and when our patient have a bad condition, we lost the time for this transplant. Yes, it's really depends on the patient's condition, but we have exactly the when we should do this, and it I think various things are involved in our decision. Thank you.
Thank you so much, Dr. Asari. Dr. Asari is one of my colleagues working in our center. Okay, is there any question?
Dr. Sadeghi, I have shared the result of the article that Dr. Asma Ashari shared. It's about Dr. Salehzadeh's question that if we need a new criteria for classifying monogenic patients, and this article with the authors is Al-Mayouh and his colleagues reports that their study demonstrate ACR 2009 criteria efficiently classified monogenic lupus patients, irrespective of the diversity of the underlying genetic variants that they may have. So this classification criteria also works for these patients.
Okay,
Thank
so
you.
we can rely on this kind of classification for monogenic lupus patients.
Yes.
Okay. Okay, I got a message from Dr. Al-Islehi that she and her colleagues couldn't connect to our program today, and we miss them so much, but I didn't know what happened because connection of the, Dr. Niz was very joyful for us, because it showed us that the connection, that was not a problem with the connection. So maybe there was something wrong with okay. I got a message from Rosie Close. We have just managed to join from Southampton, UK. I must tell to Rosie that I checked the connection specification, and the one I sent you today was the same as I sent you before. So I don't know what was the problem. Okay. Okay. Sorry. I told all the guests that we recorded this program, and I will send you the link for you and also Dr. Alice Leahy and all other dear colleagues in Southampton to see the program if they like. Thank you so much. And if there is no question, okay, sorry. We can finish the program, and I hope see you again very soon, especially after summer vacation in each country. I mean in Norway, in Southampton, and also in England, and also in Iran. Thank you so much. Again, thank you, Dr. Kosar, Dr. Nassim, for your great presentation. And see you next time.
Goodbye. Thank you all.
Okay. Sorry. Sorry, Dr. Alice. Sorry, miss you so much.
That was so sad. We were desperately trying to get in.
Okay.
What
I
a
don't
shame.
know what happened. No.
Is it recorded, Payman?
Yes.
Oh, great.
And, I will send you. I will send you the link later.
Thank you so much, and we'll meet again soon. We've got a great case to share with you. So.
Okay. You told me that you have a good case to present, so we are looking forward to your presentation, and also we try to be in touch in what we can say in a timely manner, and try to set up program for our presentation. I know in Norway most of our colleagues are in summer vacation, but maybe later we can have presentation from Norway, especially from Dr. Ellen, that we miss Dr. Ellen today, and we can continue our program with other centers.
Lovely. Thank you. I look forward to looking at this recording anyway, and
okay.
We'll see you again soon.
Okay.
And hello, goodbye, Norway.
Okay. See you soon.